Good afternoon, everyone, and thank you for joining PHA Classroom for the first webinar of the Newly Diagnosed series, Newly Diagnosed, Test, and More Tests. What is pH diagnostic testing telling my doctors? I am Lori Lopez, the Patient Education Program Associate at the Pulmonary Hypertension Association. Today's webinar will be presented by Deedre Boekweg. Deedre Boekweg is a clinical nurse coordinator for the Pulmonary Hypertension Center at the Intermountain Medical Center in Salt Lake City, Utah. Deedre received her MSN at Weber State University. She began working with PH patients as an intensive care nurse in 2000 and transitioned to working as a PH clinical and research coordinator in 2007. Deedre is an active member of the PH Professional Network, serving in multiple positions, and is currently on the Education Committee. She is also a member of the SLC Zebra Support Group. Without further ado, please welcome Deedre Boekweg.
All right, hello or good evening, everyone. I'm Deedre. I'm excited to have everyone here with me. We're going to talk a little bit about some learning objectives, about clinical tests and how those work with the diagnosis of pulmonary hypertension, the basics of how pulmonary hypertension presents or works, the differences between the tricky terms of pH and PAH, which are used kind of in some ways interchangeably, and we'll go over that, and also to recognize that there are multiple therapies for use in pulmonary hypertension. So to start off, this is for newly diagnosed patients, so we're going to keep everything fairly simple and talk about the common journey to a pH diagnosis. So symptoms of pulmonary hypertension are a little tricky. They're somewhat unclear or not very specific in nature. So most patients who have pulmonary hypertension present with a little bit of shortness of breath with activity, or physicians will say dyspnea on exertion, just meaning that when you're sitting and relaxing, you feel great, but when you go to exercise or increase the activity that you're doing, you often will feel short of breath. Fatigue can happen, swelling, especially in the legs, but also sometimes in the abdomen or in your belly. Chest pain or pressure can happen, sometimes with activity or not. Fainting can happen. That's kind of a big signal, but it does happen for some patients. And also fast heart rate, palpitations, or cough. And so a lot of people have those symptoms. And because they're so unclear, it is not uncommon in the journey to the diagnosis for patients to have a hard time to get that diagnosis. We know by the REVEAL registry that was done that 1 in 5 patients have greater than 2 years between when they first have symptoms that they're feeling and when the disease is actually recognized as pulmonary hypertension, which is really tricky. And it's because there's lots of different diseases or that have these same common symptoms: fatigue, swelling, shortness of breath. So oftentimes physicians will take a look at that and say, oh, you know, if you're young and you're in your 20s and you're short of breath when you're having activity, well, gosh, maybe that's asthma. And so they'll treat people for asthma, but the asthma isn't getting better. And so in that lag time, patients often can end up seeing multiple physicians and having multiple different tests ran in that process. And so as we all are moving towards a diagnosis, most people will have those symptoms or maybe a few different. I have also had patients who don't have a whole lot of symptoms where the testing actually is what made people think about pulmonary hypertension before they were having symptoms. So, which is really a little bit different, but that's an okay thing as we're maneuvering forward. So when you start out about being diagnosed, we have symptoms, we're trying to figure out exactly what's going on. I like to minimize or make things as simple as possible. I don't know if any of you guys have ever read the book, All I Really Needed to Know, I Learned in Kindergarten. And I have found that I try very hard in my life to keep everything nice and simple. So with pulmonary hypertension and learning how we kind of maneuver through to get a diagnosis, I tell my patients this is how it works. We've got 3 questions we're going to ask. I know it's super simplified, but 1, do you have pulmonary hypertension? 2, why do you have pulmonary hypertension? And 3, how do you treat pulmonary hypertension? And we're going to actually go over these every little bit because they all help out when we look at them nice and simply that direction. So this is a diagram of the heart and lungs, and I just wanted to take a minute to kind of review over blood flow through the heart and out into the lungs. I know a lot of us looked at this when we were in high school, etc., and then depending on where we've been in life, we don't see it very often. So blood returns from the body from the inferior and superior vena cava. So it comes right up and it comes here into the right atrium. It goes through the tricuspid valve into the right ventricle. It's pumped from that right ventricle up through the pulmonary valve. It's right here, and then up and into the pulmonary arteries on both sides to each different lung. And then from the pulmonary arteries, it comes out till it gets teeny tiny. These vessels get as small as the size of the hairs on your head. That's how nice and small they get. And at some point, they turn from arteries into capillaries, and they literally just maneuver so that they go around out to drop off carbon dioxide, pick up oxygen, and then they come back into the left atrium from the pulmonary veins into the left atrium, through the mitral valve, to the left ventricle, then through the aortic valve, which is right here, and then out through the aorta to your body. And as it maneuvers through your body, we use it, and then that whole process continues over and over again. And so when we talk about pulmonary hypertension, it's this system that's really involved. It's the vascular system of the heart to the lungs, and so pulmonary hypertension. Simply the definition of pulmonary hypertension, this is really quite simple, is it's a resting mean pulmonary artery pressure at or above 25 millimeters of mercury. So when we talk about blood pressure, everybody here has been to a physician's office, had a blood pressure taken. You have a systolic number or your top number, a diastolic number, or the bottom number of that blood pressure. And a mean pressure is literally just a calculated number from those two to give you a mean. So a resting pulmonary artery pressure above 25 tells us that we have pulmonary hypertension or high blood pressure of the lungs. And so it would be great if we could just take a quick peek like we do for people when they have systemic hypertension. We put a blood pressure cuff on their arm and check that blood pressure, which is awesome. I love this picture. Unfortunately, it's not quite so easy. So when we come back to the diagram and take a look, where we're trying to figure out where the pressure is high is in that pulmonary artery, and it's inside your chest and down deep. So there's really not an easy way to take a quick look at that. So we have to start looking at different types of testing that we can do to find out what the pressure is in those pulmonary arteries. Sometimes people call it the other high blood pressure. So there's an entire huge list of diagnostic testing, which is often done for patients who are being worked up for pulmonary hypertension. And I've split them into two categories. So to answer our two questions, the important questions: one, do you have pulmonary hypertension? And two, why do you have pulmonary hypertension? Echocardiograms and right heart catheterizations are two tests that are done that work to help us to understand, do you have pulmonary hypertension? They also give us some information about why you have pulmonary hypertension. There's lots of other tests that we can do to help figure out why patients have pulmonary hypertension. So lung function test, 6-minute walk, chest x-ray, radiology testing that is done, as well as some sleep studies, etc. And I'm going to go over each one of these a little bit in further depth. So an echocardiogram. So it's really a simple ultrasound. I often tell patients it's just like an ultrasound that people think about when somebody's pregnant. It's just an ultrasound of your heart. And it gives us some really helpful information. It talks to, when we take a look at it, I often tell people it's literally simply the senses that we have that we use. So often this is in views or images. It's pictures of your heart that people are taking a look at, and then we'll have cardiologists or pulmonologists read those to extrapolate information from the pictures. So with the ultrasound testing or echocardiogram, we are able to take a look at the heart chamber, the actual sizes of the heart chambers, the function, or what I often call is the squeeze of the heart. The heart is a pump, so we want to see the size of that pump, the squeeze of the pump. And the other thing that we can do is get an estimate of the pulmonary artery pressure, which is often referred to as an RVSP. It's a simple test done with the picture. You can see there's just a transducer that is used to send sound waves to echo back to show us the pictures of the heart. I've gone ahead and put a couple images in, so it's important to see. This is a 4-chambered picture of 2 different hearts. Now, I'm going to organ test because it's a little bit different in echocardiogram. When you take a look at a heart, this is a heart that's been turned upside down. So, I'm going to use my mouse. This is the right atrium. This is the right ventricle. And then left atrium and left ventricle. So it's just upside down, a little backwards from what we think when we look at a heart. This is a normal heart. So when we take a look at it, the left side here is much larger than the right side. And that's normal. If you think about the workload that the heart has to do, that left side of the heart has to pump blood from your heart all the way down to your toes and make sure there's enough pressure for it to come back. So it works much harder. The right side sends blood literally from the right side of the heart just to the lungs, which is just right next door, and back. And so when we often think of the heart, the right side is the weaker or the smaller side. It just doesn't have to work as hard in a normal heart, so it's much smaller. In taking a look at these 2 different images, this is a heart with pulmonary hypertension. You can see that the right atrium is dilated, the word that the physicians use. It just means it's stretched. It's stretched out. It's dilated. And here, the right ventricle is nice and small. You can see it in the frame of the echo. Whereas this, the right ventricle has gotten large, and in fact, it goes off of the screen that you can see. The heart is simply a muscle, the same as your arm muscle. So if you were to go out to the gym and start to work your bicep by picking up a barbell and working, over time that muscle starts to grow. And you can see that there's a difference. Here the muscle is thicker with pulmonary hypertension because it's having to work harder than it is in this image. So the other thing that we kind of are able to take a look at, right, those are the heart chamber sizes that we talked about. The other thing that we can take a look at is the squeeze, or how well that's functioning. I'm going to go ahead and hit play on these images so that you can see them with the hearts actually pumping. You can see that the motion, it is a pump, and so the motion is big as we're taking a look at the function, because we're just wanting it to move blood. The entire goal is just to move blood. And as you see that this has a nice good squeeze coming in from the side, this one a little bit less, and it's a little harder to see sometimes. The other bit of information that we're able to see, not in this view, but it's the same view. This, let me get my mouse, right here is the valve. And when we take a look at that nice tricuspid valve, we can see blood that's going through here. They can put it on an image where they're measuring how fast blood is moving, or a jet that happens between that valve. And they use that jet to put into an equation to estimate the pressures in the pulmonary artery. And it is exactly that, an estimate. It is put into a calculation. So if that estimate is wrong, it can lead to a different, or an estimation of that right of the pulmonary artery that is also incorrect. So when we look at an echocardiogram risks, we talked a little bit about the estimation may not be correct of the pulmonary artery pressure. I often view it as thinking about this. If you're looking at a bike tire and you're trying to figure out the pressure, it's like reaching your thumb down and pushing on that bicycle tire. And you can tell me, it's high, it's low, but you can't really tell me much more than that. You can just kind of get an estimation of what that pressure is in the bike tire. But it does help us to be able to see all of that. The benefits are we can definitely see how the heart is working and functioning underneath the load that it has to work under. It's not invasive, which is a big word we use in medicine oftentimes, just to say it doesn't require needles. It's not requiring getting into any different area of your body. It's literally done with just some ultrasound jelly, and it's sending a sound wave. So it's really easy to do, and it's easy to repeat. Most people say an echocardiogram is not a hard test to have done. People are usually in a room with the lights down, and you can almost take a nap through it. The other test that we talk about doing to help us understand if someone has pulmonary hypertension is a right heart catheterization. Often done as an outpatient procedure where a catheter, and a catheter is the name for just a small plastic tube, is used to actually be floated into the heart to check the pressure. And so a lot of people get really nervous when I talk to them about this procedure. And so I want to kind of go over a couple of things. The picture down on the left side of the screen is an actual picture of a catheter that is used to go and to float through your heart. And I put a pen next to it so you can see how nice and small it is. It is a teeny tiny catheter that is used. And it can be, we want it to get into your heart, but there's lots of different access sites that we can use to get it there. People oftentimes, we can use people's necks to go into a vessel in their neck to then float into the heart. Some people, we can use their arm, vessels down in their arms. And for some people, we'll use the groin. Those are just kind of easier areas to get access to a vein, and then we just literally float it on in. Sedation can be used for some patients if they're really nervous, or they just want to have that nice, hey, I'm relaxed and I don't want to remember this a whole lot. Sedation can be used for this procedure, but it does not have to be used. I find it very interesting that historically the first right heart catheterization was done in 1929 by a physician, Werner Theodor Otto Foreman. And he was trying to explain and understand that we can learn more about the heart by being able to check the pressures and to be able to get into the heart. And he was trying to figure out how to get people to understand that this would be okay, and he could not get anyone to give clearance to be able to do this in an experimental fashion. You can imagine. Well, he actually did the first heart catheterization on himself while awake, and he was actually able to do that entire catheterization procedure on himself. So I tell people, you know, we have to sit down and remember it is an important test. There is a lot going on, but it can be done. In fact, we do it all the time and very safely. So this picture on the left shows us oftentimes where we will use the neck, and we go down and we get into the vessel in your neck and float that catheter down and along till it comes into that right atrium, right ventricle, and then it will go right up and out to the pulmonary artery. They are able to get pressure checks in each of those areas, which helps them to understand about how the heart is functioning and how the pressures are in all of those chambers. We often talk, most importantly, about the pulmonary artery pressure. So normal pulmonary artery pressure is about 15/2. So each of them have a top and a bottom number. We often can talk about them in a mean artery pressure, which most people are used to hearing from their physicians. The mean is normally 9 to 18. So 25 and above is what we consider pulmonary hypertension. One of the other things that's very important that we can get from a right heart catheterization that we are not able to get as accurately by echocardiogram is a cardiac output. It's a big word. It basically is talking about the amount of blood that pumps through your heart in a minute. And so normal cardiac output is about 4 to 8 liters per minute. And when you start thinking about how much blood that is a lot of blood that moves through our hearts every single minute, and that's a lot of work that goes on. But it's important that we need the amount of blood maneuvering through our bodies to help us to be able to do the activity that we need to do. And so in understanding that, not just the pressures, but the cardiac output, because the goal of the heart is really to move the blood, that's what helps us. So risks of a right heart catheterization. It is an invasive procedure. So because of that, because they're actually going to enter the skin a little bit, just like with an IV, you may have some bleeding or bruising at the site. There's a rare complication where you can have a partial collapsed lung, or maybe some injury to the vessels that they're going into. That does not happen very often. I've been working in pulmonary hypertension for 10 years, and it is not common at all to have those, but they are a risk of the invasive procedure, which is why we don't do them weekly. There are also risks that happen with sedation, but in any area that you're at or any hospital, they watch those carefully and watch your oxygen levels and your blood pressure, and that's why we do it in a hospital. The benefits of a right heart cath is it is the gold standard for diagnosis. Gold standard just means there's nothing else to compare. No questions asked. Right heart catheterization is key for diagnosis of pulmonary hypertension. If I think back to how I look at an echocardiogram and say it's like using your finger on that bike tire, a right heart catheterization is like getting the tire gauge out and putting it on the tire and saying, my pressure is 35. It is an actual capture of the actual pressure that's going on in your heart. So it has exact measurements. One of the other benefits of a right heart catheterization is there is an option where we can test some medications while you're in a right heart cath so that we can give you the medications. There's some different medications called vasodilators, and have you on those for 5, 10, 15 minutes, and then recheck the pressures and see if there's an immediate response to those medications, which is helpful for some patients with pulmonary hypertension. So we're going to talk about some other types of testing as well. Lung function tests or pulmonary function tests are often done, usually done in a clinic. Spirometry is a test where you just breathe in and out. There's a tech there that works with you to help you to hit the right amounts. Breathe in now, breathe out, out, out. Those of you who've had this know exactly what I'm talking about. It helps us to understand the function of the lung, the actual alveoli, how we're moving air in and moving air out. Not the vessels as much, but the lung tissue. They can also do some other tests that can help us understand how oxygen crosses over in the alveoli. The 6-minute walk test is not a favorite of any of my patients, I will be honest. But it is a test where you walk for 6 minutes, and it's very helpful for us to understand the lung function and the cardiac function with activity, or what causes limitations, which is helpful for us with pulmonary hypertension. Blood testing, we all love to have labs done. It gives us multiple labs can be drawn. Basic health assessment, kidney function, liver function, how the blood counts are, red blood cells, etc. in your blood, as well as some specific diagnostic labs. which are helpful. Pulmonary hypertension can be related to diseases like rheumatology or connective tissue diseases. Some of those have specific labs that can be ran to help in the diagnosis. And sleep studies. So a lot of our patients will have overnight oximetry studies. The picture to your right is literally an oximeter, which most people have had on their finger at the doctor's office. But it's where you wear that oximeter over nighttime to help us understand if your oxygen levels are going low at night. And then if they are going over at night, sometimes we can then do a test called polysomnography, which will help in determining why or what is causing those levels to go low during the night. So it's helping us understand the lung function while you're sleeping. So if you notice, we're kind of taking a look at the lung function when you're at rest, when you're having activity, when you're sleeping, to understand how that's working, because the heart and lung are combined and they work right alongside each other. So effects in one will affect the other. Radiology testing is always a favorite of every patient. We often go and have radiology testing and we don't get to see or understand what those tests are. So I am going to go over these each a little bit. So a simple chest x-ray, most people have had that before. It's a picture of your lungs, which helps us to understand what the lungs look like or if there's any infection, etc. in those or nodules. And it also gives us what we call a cardiac silhouette, so the size of the heart, which is helpful for us to take a peek at. CT scans of the chest can be done for a couple of reasons. That would be the two images down to your left. We have ones that are done without contrast, that are actually looking at the tissue of the lungs, which is what this scan is specifically, which helps us to understand if there are any other diseases of the lungs, like COPD or interstitial fibrosis. We can also do CT scans with contrast, where we're looking more at the vessels. And you can see these are two vessels that we're looking at here. This is the aorta, so the contrast has not quite made it here, but this is the pulmonary artery. And so we are clearly looking right at the vessels in the lung to help understand if there are any problems with those that are going on. Nuclear lung scan, or what's often called a VQ scan, can also be done. I tell my patients that this is kind of a chest x-ray super. So it starts out with a simple chest x-ray, which tells us that and shows us where oxygen is going or if there's any differences. And then we use some contrast that is used by IV, and then as well as your breathing in two different, and it helps us understand where the blood goes in your lungs. So this is a normal lung. You can kind of see here's one lung, here's another lung, and this is where your heart should be. But the black areas are where the blood is getting to, which this is a normal lung. It looks nice, and you can see there's good blood flow. This is a lung that has some clots or some barriers that are making it so that the blood cannot get to all areas of the lungs. There are literally clots in the vessels. And so as you see, there's not as much blood that's getting to everywhere in the lungs, and if we need the lungs to function, we've got to get the blood into that same area. So you can imagine that it can cause big problems when instead of having a nice full functioning lung, you have a smaller area of the lung. Cardiac MRI is sometimes done. I did not have an image, but it helps us to see the heart and see how the heart is functioning, more like an echocardiogram, but a little bit different images in the way that they get them. But all of this diagnostic testing is to help us understand how we can see those heart and the lungs and how they're functioning. The pulmonary angiogram, I apologize, I don't think I mentioned before. This is a picture of a pulmonary angiogram, which I think is super helpful for us as we kind of look at it. So this is a normal lung, and you can see it as it comes into the pulmonary artery. Here it is branching off. This is how the blood vessels in those in our lungs branch off. They branch off to teeny tiny size, and you can see how that's a beautiful branching off. For some patients with severe pulmonary hypertension, they can have problems with their vessels, and because of that, some of those vessels no longer work, and they can have less blood flow through their lungs. But that's exactly what we're looking at with a pulmonary angiogram. It is the vessels or the blood flow in the vessels of the lungs. Our second question is why we have pulmonary hypertension, and all of the other testing that we did helps us to understand why. And I want to talk to you a little bit about why it's so important to know the relationship. I don't want to say causality, that's a little hard to say that it's the cause of our pulmonary hypertension, but what it's related to. So all of the pH experts have gotten together and created what we call the World Health Organization Diagnostic Classification. It's a really big title, or WHO classification. We talk about why you have pulmonary hypertension. All patients who have pulmonary hypertension will fit into one of 5 categories. And each one of these categories is different in the function or the way that they have pulmonary hypertension or the area that's affected. And so I wanted to have a chance to talk to you about each one of these areas because you should fit in to an area. And it's important when you're talking to your doctors to say, do I have pH? And then why? Why do I have pH? Because that can be very helpful. We're going to go over each of these groups specifically. So group 1 is pulmonary arterial hypertension. And this is where it gets really tricky. So we often hear in the PH community the word PH, pulmonary hypertension, and PAH, pulmonary arterial hypertension, can sometimes be used interchangeably. But if we're looking specifically, pulmonary arterial hypertension is high blood pressure in the pulmonary arteries because of an arterial change or problem. The actual disease or the disease process is right in that vessel. So in group 1, I've got a picture, animation here at the top. This is what's considered a normal pulmonary artery. We have kind of 3 layers to our vessels in our lungs. And you can see that the first layer is nice and thin, then we kind of have a muscular layer, and then an outside layer. This is actually a picture taken from a lung biopsy of someone who does not have pulmonary hypertension. You can see that vessel is nice and open, blood can run right through there. Again, these are the vessels that are the size of your hair, so it's magnified many, many times. With pulmonary arterial hypertension, what happens is a couple of different things. The inside lining of the vessel kind of overgrows. The muscle itself goes ahead because there's a higher pressure. It gets thicker. And so this is another vessel of somebody who has pulmonary arterial hypertension. You can imagine how much harder it is to get blood to go through this opening than it is to get blood to go through this opening. And so the higher the resistance, or the harder it is to get through that vessel, the harder the work for the heart. I happen to talk to people that it's just simple when you're out watering your garden, it's the same as putting your finger over the end of the nozzle. That pressure goes up when you put your finger and occlude half of the end of the hose. And that's exactly what's happening in our pulmonary arteries with pulmonary hypertension is as that area gets narrow, the pressures go up. Now in group 1, there's lots of reasons why we can have those changes in the arteries. These are the same idea, different pictures, but the same exact idea. Inside this, we've got multiple categories. So idiopathic pulmonary arterial hypertension is a big word that one of my favorite patients in the entire world said, oh my goodness, you're telling me I'm an idiot. And I said, no, 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 no. Idiopathic is a medical term that basically means we don't know why you have it. It's happening outside of any other process, and it just is. And so there are patients who have pulmonary arterial hypertension independent of any other issue. Heritable, so there is some genetics or family connection that can happen for a small portion of patients with pulmonary arterial hypertension. Drugs and toxins have been known to cause this problem. Connective tissue disease is related, like scleroderma. Patients who have HIV or AIDS can have an effect on those vessels. Portal hypertension, which is an issue with your liver, that can also cause that, or congenital heart diseases where people may have holes in their heart that has caused a difference in the way that their heart pump functions. Group 2 pulmonary hypertension is much more common. In PHA, in the association, we often talk so much about PAH. But if you're looking at specific numbers, pulmonary hypertension group 2 is much larger in the general community. What happens is it's really a problem within the heart itself. So the left heart isn't pumping very well, or a valve isn't working correctly, or there's a congenital defect to the heart. But as the heart doesn't work well, the blood can back up in those pulmonary arteries and cause a high blood pressure. But it's not due to a change in the vessel. It's due to the left heart not working well. And so to treat group 2, we really want to treat the left side of the heart, which is really where the disease process is happening. The pulmonary hypertension is just a backup of fluid. Group 3 pulmonary hypertension is related to lung disease. So often patients who have COPD or emphysema, interstitial lung disease, sleep disordered breathing like obstructive sleep apnea or central sleep apnea, people who've had, for some reason, a developmental lung disease, or people who just don't breathe a lot. Hypoventilation is a word for not breathing appropriately or not getting enough air. And so all of those can cause pulmonary hypertension that is mild and is not progressive in nature. And to treat pulmonary hypertension with those, it is to have optimal treatment for the disease process in the lungs or the tissue of the lungs. Group 4 is pulmonary hypertension related to chronic thromboembolic disease. This is what we were talking about when we were looking for blood clots in the vessels. So people have heard of people who have pulmonary emboli or blood clots in their lungs. It happens fairly regularly. About 4% of those patients, those blood clots do not reabsorb, and they lay down fibrinous tissue. This picture is a picture of blood clots that were actually taken out of a patient. And you can imagine if in the vessels of your lungs, if you had all of that clot load, that you would have high blood pressures in the vessels that we're getting through. It's really a plumbing problem. And you treat chronic thromboembolic a little bit different. For some patients, that's surgery. For some patients, that's other medications. And the WHO group 5 is my favorite because everyone has to have kind of a miscellaneous group or multifactorial. And so these are really quite rare hematologic issues or metabolic disorders or just kind of an other category. Those categories that we've made are pretty simple, right? 1, 2, 3, 4, 5, and which group you're in. Unfortunately, our bodies don't always fit into 1, 2, 3, 4, 5. So one person can have multiple associated factors for pulmonary hypertension. So you could have a patient who perhaps has a connective tissue disease like scleroderma and may have some damage to the pulmonary artery vessels. And you may also have, at the same time, they could have had a blood clot and not reabsorb that blood clot. So they could have group 1 pulmonary hypertension, 50%, or half of a pie. And they could also have pulmonary hypertension related to blood clots or chronic thromboembolic PH, which is group 4. And so it gets really complicated in understanding. Some people are pretty clear-cut when you're able to diagnose, which is great. And some are a little bit more complex, which is also great. There's a reason why we have PH specialists and centers that we're able to go to that specialize directly in helping us to understand the difference, because the way we treat those diseases are very different. So when we go back to the kindergarten version of pH diagnosis and treatment, we've talked about, do you have pH? We do that by looking at testing. Primarily, echo can help, but the right heart cath is the gold standard. Why do we have pH? We use all of the tests that we've talked about, the pulmonary function test, the radiology test, even the echoes, et cetera, to understand which grouping that we are in, or diagnostic classification. And then the next question is, how do you treat pulmonary hypertension? And each is a little bit different in how we treat it, which is so important. This webinar does not have time to go into all of the treatments for pulmonary hypertension. It will be the next chapter or the next webinar. But I think it's important for me to show you just one quick slide to help us understand. So pulmonary arterial hypertension, or group 1 medications. The first medication was approved in 1995 and was Flolan. And if you take a look at this graph, we have 14 different therapies that are available to treat pulmonary arterial hypertension, which is amazing. And they all have come out so fast in the last 15, 20 years. It's amazing. There's a ton of hope. There's a ton going on in how we treat pulmonary hypertension, which is so very important as we move forward and look at how our journey continues with pulmonary hypertension, because it really is a journey from diagnosis and treatment to working to being part of PHA, to have webinars and learn more. It is so important for us to continue to learn more so that we can, as healthcare professionals, help patients, and it's important for patients to learn more so that they can also be informed and help with medical decisions and also lifestyle choices, et cetera, that help. So it's really neat that we're able to work on that as we're able to go from diagnosis, taking that to real life and how we live life the best that we can.